Today I would like to talk about atypical lymphocytes. You might have heard this term called atypical lymphocytes or reactive lymphocytes. But before talking about atypical lymphocytes, let's know about what are typical lymphocytes. So first of all, tell me what is the percentage of lymphocytes in our blood? In other words, what percent of WBC constitute lymphocytes? Average 30%. Range is 20 to 40% of WBC are lymphocytes. Right? And among all those lymphocytes, about 50% are CD4 lymphocytes, CD4 T cells we call CD4 T lymphocyte, and rest 50% include CD8 T lymphocytes, B cell, natural killer cell. This is the average. If you see the report, you will not see the separate report of NK cell, and you know NK cell constitute 10 to 15% of all lymphocytes, but you won't see the report of NK cell because the machine cannot differentiate different cells, CD4 cell, CD8 cell, B cell, NK cell. So machine will count everything as lymphocyte. So if you want to know the exact percentage of CD4 lymphocytes, it is like 30 to 50% of all lymphocytes are CD4 cells, and 20 to 30% of all lymphocytes are CD8 cells, and 10 to 20% of all lymphocytes are B cells, and 10 to 15% of all lymphocytes are natural killer cells. And what is the definition of lymphocytosis? If total lymphocyte count, if absolute lymphocyte count is more than 4000 in 1 microliter of blood, in 1 microliter of blood, if the count of lymphocyte is more than 4000, we call lymphocytosis. And if the count in 1 microliter blood is less than 1000, we call lymphopenia. We do not use percentage in the definition because it will give erroneous result. If like say, let's say WBC is 30,000 versus like 2000, so we do not use percentage, we use 4000 and 1000 cutoff for lymphocytosis and lymphopenia. Now let's come to the proper topic, atypical lymphocytes. So atypical means which is not typical. So what is not typical? So this term was given by pathologists because when pathologists look under microscope, they look like there is a shape of lymphocyte, inside there is big nucleus, right, and cytoplasm is pinkish. But they found that cytoplasm, in the border of cytoplasm, there are bluish in Romanesque stain, there are bluish things. So what is this bluish thing? So this is not typical, so they call it atypical lymphocytes. And they later found it occurs due to variety of infections like viral infections, CMV, EBV infections, HIV, or even Bordetella pertussis, which is bacteria, even bacterial infection, which is I don't think any bacterial infection causes lymphocytosis except to Bordetella pertussis. So this is basically a reactive process where body is trying to activate the lymphocytes to kill the pathogens, to kill the virus. So when there is activation, there is increased protein synthesis, and due to increased protein synthesis, you will see the bluish margins in the cytoplasm. And you can also see that there is more prominent nucleoli. If you see more prominent nucleoli inside the nucleus of the lymphocyte, it is also atypical. Prominent means it is active, it is reactive. If there is some infection, so it is fighting. So that is atypical lymphocyte. So what is the cutoff to say that there is reactive lymphocytosis? So there is no defined cutoff. Like if you say the definition of CMV viremia syndrome in transplant patient, we use cutoff as 5%. If it is more than 5% reactive lymphocytes, we can call there is CMV viremia. But in others they count as 10%, 20%. Anyway, if it is more than 5% reactive lymphocytes, you can guess there is some infection or some pathology where there is activation of the lymphocytes, right? And as I already told you that we cannot differentiate under the microscope whether it is B lymphocyte or T lymphocyte or natural killer cell. Those are only done by immunostaining and CD markers.